Hey there, it's time to take the lead. Trust your voice, know what you need. Let's break it down.
Welcome to Beyond Clinical Walls with your host, Dr. Bayo.
Claim your life.
The ICU, just hearing those letters can make your stomach drop. As a family medicine doctor, I've had to send patients to the emergency room and then call their families to say, meet them at the hospital. They're going to the ICU. And I can hear it in the silence on the other end of the line, the fear, the confusion, the feeling of complete helplessness. Here's what I know. Most of us either will be in the ICU ourselves or have someone we love end up there at some point in our lives. But very few people actually understand what happens in those rooms, what all those beeping machines mean, or what questions we should be asking the medical team. And that's exactly why I wanted to have this conversation today. If you are new here and you've landed on this episode, welcome. I'm Dr. Bayo, your health advocate. I'm a practicing family medicine physician, and I bring what I see in my clinic into the work that I do on the news, on social media, when I travel across the country speaking, and to this podcast. My mission is simple: help you understand your health and the healthcare system better so you can advocate for yourself and your loved ones. And today, I brought on the best to help us understand what really happens in the ICU. Dr. Mahmoud Ibrahim is a triple board certified physician in internal medicine, pulmonary medicine, and critical care. And he works in the ICU at Nacogdoches Medical Center in Texas. You may know him online as ICUBOY, or his friends and colleagues call him Moody. Welcome to the show.
Oh my God, thank you so much, Dr. Bayo. I'm so honored to be here.
I am so excited to have you here. Well, let's start first with some really deep stuff with some rapid fire
Sure,
questions. Are you
let's do
game?
it. I'm game. Let's do it.
Let's do it. The first one is, what drew you to critical care? And was there a moment you knew this was your calling?
Yeah, it's a great question. Honestly, one of the ICU nurses actually told me that she thought that I had a good ability to explain things to families and that I stayed very calm even in very stressful times. And so it was actually the people around me who pointed it out to me that maybe this is a good field for you. And my chief resident at the time also, I remember, kind of said the same thing. And so, yeah, just the people around me, I was lucky enough to have a lot of people who could guide me.
That's awesome. I love that. When
Yeah.
you surround yourself around people and they get to see, what you are best at, they're telling you
Yes.
like, oh my gosh, this is your calling. And you were able to listen to them because sometimes we miss that boat and you listened and I can already tell, this is your calling and it was the best place. Okay. So next question. What's the biggest misconception patients have about the ICU?
Oh, that's a good one. There's probably a lot of them. There's a lot of reasons that someone can end up in the intensive care unit. And so I think most people hear ICU and they immediately think like, oh, like there's no way they're going to survive or it's catastrophic. Or some people don't really understand, like you said very well, Dr. Bio, like what exactly goes on in the ICU. So probably there's a bit of confusion around what it is we exactly do. And there's a bit of confusion about, does everyone who comes to the ICU have the same chances of survival? And the answer of that is completely no. Like it's the variation in the spectrum is tremendous. And then I think there's a lot of misconceptions around what the ventilator does, what the different machines do. There's a lot of misconceptions. And I think especially nowadays with everything going on around us in the world, I think there's a lot of fears around doctors and hospitals and do we have patients' best interest in hand? And the extreme side of things, I think sometimes patients can be really scared. And so I think it's really great what you're doing to kind of like bridge the gap and bring us closer because hopefully by humanizing us a little bit more and having people see that we really are just regular people and we very much care a lot about our patients. And that is pretty standard across all hospitals and all doctors. So I think there's misconceptions all through that process. And it makes sense. People come to the ICU, they're scared, they're feeling a lot of things, they feel like overwhelmed. And so that can bring up a lot of emotions. And some of them, those emotions might be anger or distrust. And so it's great to be able to be here and kind of try to bridge that gap a little.
And just like you mentioned, the feelings of anger, mistrust, and then you have an illness on top of it that
Hmm.
you were likely not expecting. So
Right.
all three components really make it
Hmm.
a recipe for it's challenging to even take in
Very.
your environment. And then those thoughts, those fears really spill over in a way
Yes.
that wouldn't normally because of the situation.
Absolutely. And by no means do I have any judgment or really criticism for any patients or their families. I think it's a totally normal human reaction. You are put in this bizarre situation that a lot of times came out of nowhere. Even if we as medical professionals maybe could have seen it coming, maybe no one had talked to that patient or their family member and explained to them how sick they are. A lot of patients who are walking around every day with chronic medical problems, especially things like congestive heart failure or advanced lung diseases, a lot of them feel pretty fine. And a lot of times, no one has really told them, hey, this is at this stage, and, we can only do these many things. Everyone's life is going to come to an end at some point. I know that it's a kind of a taboo and difficult topic, but it's so much of what we do in the ICU is navigating death, right? It really is navigating the end of life. And of course, a lot of our patients survive, and that's amazing. But sometimes we really are just bridging people to the end of their life. And so that evokes a lot of emotions for people, which is very normal. I've asked people who are in their 90s, have you ever talked to your husband who's sitting right next to you of 50 years about what you would like done? And they look at each other and they're like, we've never talked about this. It's not a standard conversation for a lot of people.
I love that you mentioned that because the conversations that happen in the hospital are not that
Right.
normal back and forth. Okay,
Right.
next question. If
Okay.
you could get families to understand just one thing when their loved one is in the ICU, what would it be?
The most important thing is knowing that we are 100% on their side, and we are 100% thinking about the patient in every single way, and we care tremendously. And even if we might appear, stoic or not react with a lot of emotion to different things, a big part of my job is staying very calm, even in very disastrous situations. So we are very deeply invested. When I go home at night, I'm still thinking about my patients. When I'm off, I'm still texting staff to hear what's going on with the patients and if they got better. So we are there for you. We work for you, and we care very, very deeply about you and your family member.
Yes, we do.
Hmm.
What's one question you wish every family member would ask but rarely does?
I think I really like being asked about, what to expect in the next day or so, or what might be data points to pay attention to. The ICU is like an ocean of data. There's so many numbers and things beeping, and I've seen family members get really fixated on really small pieces of data, like, oh, this number looks like this, but yesterday was that, so that means they're getting better, right? So, and that's normal. That's normal, and so I think asking us to help guide them as to what pieces of information we are paying attention to really tell us what is changing and what's important and what's not. I love that because then we can all be on the same page. The challenge is when we're not on the same page and we aren't speaking the same language, so to speak. So I love when we can kind of get ahead of things and anticipate things together.
Well, that's why this episode is so important. We are
Hmm.
going to help people get on the same
Yes.
page and they're going to have a better understanding of that ocean of data. I love how you
Yes.
said that. So
Yeah.
let's start with the basics. Let's talk about when we explain the ICU, what does that mean? And how is that different than a regular hospital room?
It's a great question. A lot of it is basically the intensive part of the care unit is that everything is done with closer scrutiny. It's not to mean that patients that are on the regular hospital floor are not being closely monitored. They are, but simply from a resource standpoint, the ICU concentrates a lot more resources on fewer patients. And so these are patients who are being monitored extremely closely. And nurses who maybe would typically have 5 or 6 patients on a regular floor have maybe 1 or 2 patients in the ICU. So there's a lot of attention going to those patients, and there's a lot of monitoring and following up 24 hours a day. So that's how I see the ICU. And the people who come to the ICU basically have some degree of threat to either their life or to an important organ in their body. And that's why they're in the ICU. We're either treating something or we're monitoring something.
That word critical, because a lot
Hmm.
of times people want to know, what is the difference between that regular room and the ICU? And you shared it. It's something critical. It's something trauma. It's
Hmm.
something that cannot be met on a regular hospital floor. But care is given on both sides. But when you have trauma, you have more needs, which requires more intensivity on that one patient. And that's why you often just see one or two patients, but
Hmm.
really having this very specific team
Hmm.
surrounded around what can we do to make sure everything that we can track as closely as possible. So let's talk about the ICU team, because there's a lot that's happening. We talked about the data. We talked about this lovely team. You're, in this hospital room, you have your loved one there. You see tubes often, you see the data, the beeping. Can you walk us through, with people coming and going, what role does every person play? And I know there's a lot of people, but even if you could just pick 2 to 3 people just to help people kind of identify if they find themselves in this situation.
Sure, sure. I would also empower people, if you see someone coming and you really don't know who or what they are doing, you are 100% entitled to say, excuse me, could I just ask, who you are and what your role is in taking care of my mom, my brother? Because I totally agree. And if we're not doing that, that's on us. We should be, because absolutely anyone who enters that room really needs to clarify what their role is. I would say probably the most important person in every ICU is the nurse. I think the ICU nurses are the backbone of everything. And especially for the patients and the families, they are really the person who is going to be there for 12 hours. And then after 12 hours, another nurse is going to come and be there for another 12 hours. So that is your best friend. That is your compass. That is your North Star. You know what I mean? They are really the ones who are going to be able to tell you, like, hey, so and so came in and did this, so and so came in and did that. That person over there is so and so, and this is what's changed in the past hour. I could not do anything at all without the ICU nurses. So the ICU nurses is really a focal point for you and your family. So the most important person I would say for you to identify is, can I meet the nurse that's taking care of my brother and my sister? Can they introduce themselves? Can we just touch base? That's so important. And then, obviously the physician is an important member of the team. Depending on the structure of the ICU, there may be different types of physicians and there may be different ranks of physicians in your ICU. So a good question to ask is, who is the attending physician? The attending physician is like what I would do, someone who's completed their training and now is practicing unsupervised. So who is the attending ICU physician? That's the main physician who's taking care of your loved one. Now, in some hospitals, they have what's called an open ICU, which means that the ICU physician is not actually there all the time. They're there in the morning or they round, and the hospitalist is actually the one who's there all the time. So it's good to ask, is the ICU physician here? Are they here all day? How does it work? Some hospitals have trainees in them, like residents and fellows and students. And I cannot emphasize enough, like if you are lucky enough to be in a hospital that has residents and fellows, I strongly encourage you to welcome them as members of the team. I tell people that all the time. Some people feel like, "Oh, are you learning on my wife and husband? Are you here to learn to practice and experiment on my loved one?" Absolutely not. There is a very close supervision of these trainees, and they are an important member of your team, a very important member of your team. So obviously doctor, nurse, and then if I had to pick one else, and it's really tough in the ICU, I would say the respiratory therapist, because a lot of patients are needing some degree of oxygen. That's the person who is trained in monitoring the breathing and the lungs specifically. So they are very well trained in monitoring your breathing status, your oxygen levels. They will often pick up or coordinate with the nurse very quickly if something is changing from a breathing standpoint and alert the physician that something needs to be done differently. But just quickly, I will mention I have forgotten and would love to include caseworkers, physical therapists, clinical pharmacists, speech therapists, occupational therapists, the person that mops the floor in the ICU, like literally everyone. Like we are very, very, and I think the compliment I get the most from patients after they leave the ICU is y'all were like a well-oiled machine, and that's how it has to be. We are very close. Yeah.
It is a cohesive unit that everybody is talking to everybody. Everybody's trying
Yes.
to help, and the goal is the
Yes.
patient.
100%.
And in order for that to happen, everybody has to be in sync. And when you were
Yes.
naming each person or each one, and I had limited you to three, so that was my fault. I'm so
It's
glad you
okay.
said the caseworkers because
Of course.
they are fantastic. But it also reminds me of, I love in one of your videos you say, have you asked the name of your respiratory therapist? And I love that. And that goes beyond, finding out your nurse's name, finding out your caseworker's name. Another thing that I've found that can help even with advocacy in the ICU or even on the standard floor is share a personal thing about your loved one to
Yeah,
that staff, because that
absolutely.
allows that kind of connection, like, oh, their favorite color is blue, or something of that sort can also allow that connection. Well, this leads me to a reality check. According to the National Institutes of Health, more than 5 million patients are admitted annually to the US ICUs for intensive or invasive monitoring. That's roughly one in every 65 Americans every single year. So help us understand what this means. Why are so many people needing this level of care?
Yeah. One of the most amazing things about medicine and science is that now we are all able to live longer. And that's an amazing thing. We're able to live into our 70s and 80s, 90s. I've had more than one patient in their hundreds, which is it's just incredible. But the reality is, as we get older, our bodies start to wear down to some degree. And I think the reality is that it is very likely, if almost a certainty, really, that people that we love and care for, our parents, our grandparents, our great grandparents, are going to be in an intensive care unit at some point. So it's really something that touches us all. And I think it's hard to be prepared for these things, but at least keeping it in the realm of possibility is helpful. And I think it comes back to what we touched on a little bit earlier, which is, it's it's not it's not an enjoyable dinner conversation to talk about, life support and death and those things, but it is important. I'm in my 30s and I've talked to my wife about what I would want her to do if something were to happen to me, and what I would want life to look like after that. And of course, that's the nature of my job. So it would be odd for me not to. And for most people, that's very morbid. But it's really important because it is going to touch all of us at some point in our life. And growing old it's a blessing and a gift, but none of us are going to live forever, unfortunately.
And when we talk about longevity, and you never
Hmm.
know, my father used to say, and he passed away, he was 99 years old. So he would say, you
Mm.
never know when your number's up, Bio. You never know. And through medical school, as you and I, learning about the advanced directives, for those who don't know,
Hmm.
like what are your wishes? What would you like? And one thing that, as you were talking, that stuck with me, it reminded me of something in medical school.
Hmm.
I was told by an attending, the best gift you can give to your friends and family is the gift of letting them know your wishes.
Absolutely.
Because being in an ICU and in a hospital, and you're struggling with what would this loved one want, is so hard. I love that you and your wife, having those conversations. I've had it with my husband. And so anyone listening right now, think about it. It feels uncomfortable, but that uncomfortableness is actually a great gift that you can give to yourself and your family member by
Absolutely.
knowing your loved one's wishes. Like, that is a
Mhm.
huge thing. Well, that leads me to, you're in the ICU. We're going to go back to
Mhm.
that. And you've got the
Yeah.
monitor. I still love the ocean of data. And you see these machines and monitors.
Hmm.
What are the most common ones families will see? And if we can just break it down, what are they doing? Because I've seen those patients where they're like, I saw this number change. It was
Right.
red, right? And it's
Absolutely.
hard for them because they see
It
it's red, it's
is.
blinking. So just
Correct.
to help kind of people, help people know more about that.
Totally. Well, for one thing, every patient that's going to come to the ICU is going to be attached to a monitor, a continuous monitor that is going to be displayed on a big screen next to their bed. That's going to be very tempting to look at. And it's going to be receiving data from a lot of different machines and lines that are hooked up. So one of them is going to be a blood pressure cuff, most likely, that is attached to that monitor and is going to be cycling every 15 or so minutes. There's also going to be a heart tracing, an EKG, that's monitoring their heartbeat and their heart rhythm and reporting that continuously. There's also a machine on them. It's not really a machine. It's more like a little lead with a little plastic tip on their chest that tells us how quickly the patient is breathing every minute. It tells us their respiratory rate. And then there's a little thing that a lot of people remember. It like snaps onto your tip of your finger. It doesn't hurt, doesn't bite. It's just a little plastic thing on the tip of your finger. And that actually uses some really cool data to actually tell us about your oxygen that's in your blood and oxygen in your body. So those things are continuous. And that's the part that I think is often overwhelming for families because they're like, there's like 15 numbers on that screen. Which one is the blood pressure? Which one am I looking at? So that's the first thing, because that's something that you don't see when you visit your loved one on a regular medical floor. They're still being monitored for those things, but not continuously that way. So that's usually the biggest one. The other one is, intravenous medication. So you're going to see that they have basically like a little catheter in their vein, and medication is going through that. And there's a little tubing that goes up to a bag hanging on a pole, and those medications are going into their bloodstream directly for some reason. Most commonly, those are fluids for hydration or some sort of antibiotics to treat infection. And then the big one that I really want people to be empowered to ask about and to be familiar with, because it is so commonly used in the ICU, is what we call vasopressors. And that might be a hard word to remember. I often tell people to ask, like, is my family member on adrenaline? Because that's really what it is. It's basically a medication that is similar to adrenaline that actually raises blood pressure. And that is a very important form of life support. Depending on how much of that medication your loved one is on, they might be kept alive because of that medication. And I think that shocks a lot of family members when they're like, I thought that was a bag of fluids. You're telling me that if you stop that medication that they could die? I think I find a lot of people find that to be mind blowing. So that's a good one to ask about. And then the mysterious blue box, the ventilator, the machine that breathes for people when they can't breathe. There are other things like dialysis machines that are less commonly used, but those I would say are the big ones.
And speaking of, there's so many different things, the monitors, the
Yes.
IV, and then I'm so glad that you talked about the vasopressors because people are so surprised. They don't realize that medicine is all of that is very powerful. Well, the other thing that people can become overwhelmed with is the ventilator. Can
Yes.
you help people understand more about why a ventilator may be necessary and what families can take away when they see their loved one on a ventilator? What would be like your top couple of things that people could understand more about it?
Sure, absolutely. I would say, first of all, if you find the ventilator to be mysterious and overwhelming, you're not alone. I think a lot of doctors also find the ventilator to be mysterious and overwhelming. And outside of certain trained doctors that operate with them frequently, the ventilator is a scary thing. So, first, just want to validate that for people because it is kind of scary and overwhelming. But basically, the ventilator is a machine that is able to help the patient breathe, and it provides support so that the patient doesn't have to work to breathe on their own. So the ventilator is attached to a tube, a breathing tube that goes in, not necessarily to the lungs, but into the airway. And basically, that machine is able to monitor the breathing that your loved one is doing and support your loved one to breathe as much as needed. I think the most important thing to me that I would want family members to understand is there is a huge spectrum of illness severity for patients on a ventilator. Your loved one might be on a ventilator because they just got out of surgery and needing like 2% of support from the ventilator. And I'm not worried at all about their lungs. And tomorrow morning, once the surgery is passed for a little while, we're going to take that tube out. I'm not worried at all. And then there are patients who are on the ventilator who I am extremely worried about. The ventilator is giving them, let's say to simplify it, 100% of the support it can give them, and their body is still not getting what it needs in terms of oxygen and breathing. So I think what's important for family members to understand is, why are they on the ventilator? Is it a problem with their lungs? How much support are they needing from the ventilator? And you obviously don't need the doctor to break down all the logistics of it. You just need them to tell you, are you needing to give them a lot of support with that machine, or are they just on it because of another reason? To give you an example, someone who has a stroke, for example, a brain injury, and they become confused, they go on a ventilator, but not because they're not breathing and they need a ton of oxygen, just because we need to help them continue to breathe until they're alert enough to take the tube out. So I want people to understand that the tube goes in sometimes because of the lungs, and that can be more scary, or sometimes it goes in for unrelated reasons. So I would just clarify, like, why, how long do you expect them to be on it? Are they needing a lot of support? I think those would be really important questions to ask.
Once you're able to clarify why your loved one is on, like we said, if it's
Hmm.
for a stroke or after surgery, it can
Hmm.
be a great way to bridge into the question that I often hear family members ask. Well, I'm curious, when is my loved one going to get off the tube? When are they
Right,
going to get off the ventilator?
right,
And
right.
this helps people know it really
Hmm.
depends upon the condition. And it's really
Yes,
hard, although you want to give that patient a magic number
right,
of,
right,
on day 2 or day
right.
4,
Yes,
it's more complicated than that,
it
and that can
is.
help people understand. And if if there was one thing that you
Hmm.
use as a
Hmm.
great indicator that
Hmm.
likely this patient is going to be extubated or the
Hmm.
tube
Hmm.
taken out of their mouth, what
Hmm.
would that be?
I will say that every day your loved one is on a ventilator is a day that we are trying to get them off of the ventilator. So there's never, when I go into the ICU, actually, one of the first things I will do is look at the list and see who's on a ventilator and ask myself, can I
Mm.
get them off of the ventilator? So, like, when I say that getting your loved one off the ventilator safely is my top priority, I mean that is my top priority. Like, I am well aware that the longer that your loved one is on the ventilator, the weaker they are getting, the everything is not moving the direction we want it to. I need to find that sweet spot between letting their lungs rest and fixing the underlying problem and not letting it go out prematurely. Because I will say that even the best of ICU doctors will have to put in at least one in 10 tubes again after they take out the tube. And part of that is because we need to take some degree of risk and because we don't have a crystal ball and we can't keep it in forever. So just emphasizing that we really do as much as possible try to get that out every day. But the things that are going to push me in that direction are, is the reason that they got put on the ventilator, is that now resolved or resolving? Is their blood pressure moving in the right direction, either from being way too high or way too low? Are they needing very little support from the ventilator in terms of the oxygen and breathing support? How is their mental status? Are they awake enough to breathe on their own? And what's going on in terms of mucus and coughing? Are we going to run into any problems there? So a lot of patients are going to be getting some medications to keep them comfortable while they're on the ventilator. Luckily, we've moved away from keeping people in deep comas like we did 30 years ago. So ideally, it shouldn't take very long to wake someone up if they were on a little bit of medication to keep them comfortable. But we check that basically every day. And if they pass all those things, we actually do what's called a breathing trial, where for about 30 minutes, we get the ventilator to take a break, not completely, but kind of take a back seat. And we really work out your loved one and see what they do. And if they seem to be doing well, that's a good indicator based on the evidence we have that we might be able to take that tube out.
Those are amazing gems for the patient to take with them. And just having those questions, can help them feel empowered. And that bridges to the next question. So now that they have these fantastic questions, when
Right,
is the best time to really have that clarification where you've just received all this information from your loved one's medical team? They have told
right.
you the situation, the diagnosis. So when should they ask those questions?
I always tell people because often, let's say a patient comes in and they're very, very sick and they're now on the ventilator and they're needing vasopressors, that adrenaline we talked about earlier. I'll meet a family member for the first time, and rightfully so. They will arrive to the bedside. They just drove over from 2 hours away. Their mom is now on a ventilator. They're very sick. They have a bad infection. And immediately they're like, what's going to happen? Is she going to make it? And I tell them, I do not know. And the reason I do not know is because the way the ICU works, the more you spend time in it, is you are plotting a data point against time, and you are seeing how that data point changes over time. And so when I meet a patient at time zero, I have no idea what the trajectory is going to be because I'm initiating a bunch of therapies. And the part that I can't control is how they're now going to respond to those therapies. So I tell patients and their families, depending on how sick the patient is, the first 24 to even 48 hours, in my mind, are the most critical time in anyone's ICU stay. Of course, you can be in the ICU for 5 days and be the uncommon patient who has something go wrong that day. But for most patients, the most critical time is that initial time when they come in. And I always tell patients, let's talk again tomorrow morning, or let's talk again in a couple of days, and we'll keep updating you. By then, I will have a much better idea of which trajectory it's going. And some patients bounce back immediately. And even 2 hours later, I walk in and go, wow, they really responded great to this. And some patients go the opposite way, where I was like, hey, I said we could talk tomorrow, but actually in the past hour, things have worsened dramatically. And I'm actually really worried about tonight and even us getting through tonight. And we need to sit down and talk about this. This is not going the right way. But for most patients, that initial 24 to 48 hours will be enough time for the ICU doctor to really tell you, like, okay, we are moving here, we are moving there, or we are holding steady.
That time period of 24 to 48 hours and helping people understand that you are gathering these data points so you
Right.
can, mark it and see, because I'll hear people say, how do I know if they're getting better? How do I know if they're
Hmm.
getting worse? But now with
Hmm.
the information you shared, knowing that 24 to 48 hour is a critical time period. And then
Yes.
moving forward, we have a baseline. So those
Right.
connective dots have to happen and build
Yes.
to
Yes.
have that baseline to say,
Yes.
we're getting better, we're getting worse, or we're
Yes.
staying the same. And
Yes.
that's huge for people to have that plan. So when someone's visiting the ICU,
Hmm.
what is something that they could do to hopefully, number one, be helpful, and then also something to avoid in hopes of not causing more interference, I want to say, that can happen sometimes?
The ICU is a bit of a sacred space, so you really don't want to come in and be making like a lot of noise or a lot of commotion, yelling, all that kind of stuff. I think sometimes like if attention is needed, it can be asked for and it will be addressed without those things. I think sometimes people may be scared and they might think that by, creating a bit of a hoopla that things might be better, but actually really not. Because what ends up happening in those situations is actually my attention shifts now away from your loved one to now trying to de-escalate whatever is going on here. And sometimes that's inevitable and we're human beings and we have emotions, but as much as possible, if we can avoid creating tensions, and that's why I started this conversation by saying I really can't emphasize enough, like, we are your ally. I always tell people, like, I'm not trying to open this bed up for someone else. I have no other interest in my brain. I don't get paid more or less if something happens. My only interest is to take care of your loved one. I have no conflict of interest. And if I did, then I wouldn't be doing this job. So I would say, as much as possible, just trying not to create too much commotion. And then, if possible, trying to organize coming at the same time, or trying to delegate who is the pinpoint. When I walk into a room, I'm really quickly trying to ascertain who is the leader of this team, because it's going to be very difficult for me when I'm managing 10, 15 critical patients to update 12 family members every day for each patient. That's an unrealistic goal. And I think it's very helpful when families come in and they say, as soon as I walk in, I say, "Hi, I'm Dr. Ibrahim. I'm the ICU doctor taking care of your mother." It's lovely when patients immediately go, "I am her mother. I am so and so. She is the decision maker for my mom. My mom had an advanced directive." So being prepared in the sense that providing that information to us is very, very helpful. And like you said, Dr. Bayo, we are not so detached that we are not interested to hear about our patients. I really want to know about your loved one. I might not have 3 hours to sit down and hear everything, even if though I might want to, but I want to know what they were doing before they got into the ICU and how active they were and what they did for fun, because those things matter to me. Like, if your brother is a pianist and he plays piano and his whole life is based on him having agility in his fingers, that's what he's done for 40 years. Not that I'm not going to take care of everyone's fingers, but like, you best believe that I'm going to be very much paying attention to that, and to what's important to your loved one. So I really love it when people tell me this is what would matter to my mom, or this is, just so you have a little context, this is, she told me I would never want to be on a ventilator, or she told me I would fight to the death no matter what. Those little pieces of information can be really helpful for me.
It is, and having that point of contact
Hmm.
is vital. I love sports, and so
I
basketball is
love
my
that.
thing, and I call it, like, that's
Nice.
your point of contact, your
Yes.
coach, for the team. And
100%.
it goes back to what you said. If you can spend all your time, which you're doing, on your patient and have one point of contact, it
Yes.
allows all of your energy, all of the things that we're tracking that data point, to go
Yes.
into that patient versus trying
Correct.
to update multiple family members. And so that part is vital when it comes to, because there's a lot of decisions that are happening. We are trying to communicate as much as you can. Dr. Ibrahim, can you share with me, when it comes to delivering bad news, how to, that is a difficult thing that
It
I think
is.
you can never be prepared for because every family situation is different. How can families navigate these decisions, and what have you found that's been helpful? And I know it's hard because it's challenging. Every situation is slightly unique.
Yes, it is. Oh, it's so tough. I think, like you said, it's very situation specific. Usually in these situations, I really think the responsibility is on us as the physician to really create the environment to sit down and talk about things when things are not going well. So typically, this is the conversation that I'm having with you outside of your loved one's room. We're sitting down somewhere in a waiting room or somewhere quiet with my pager off and my phone on do not disturb, and we're going to sit and talk for as long as we'd like to talk. And I'm basically telling you, this is what I think is going to happen. These are the options we have ahead of us. And I'm trying to ascertain from you or get from you that, A, do you understand? Like, are you able to cognitively understand what's going on? Or are you really emotionally overwhelmed right now? Do you need some time to adjust to what I'm saying? Sometimes the situation is so unfortunate where we don't have the luxury of time, and I know that the family is not going to get to a point of making a decision because they're so overwhelmed. And in those situations, we just do everything we can because that's our default is always to do whatever it takes to keep your loved one alive. But there are situations where that whatever it takes from our medical perspective feels like it's causing more harm than good because it's not going to change the outcome. And I do tell people that I say this a lot in my job. Like, this is a sentence I think a lot of the nurses I work with have heard me say is that there is value to a comfortable death, and
Mm.
a lot of what we do in the ICU is not comfortable. And so, although people might think, we're giving up or we're not trying or whatever it might be, the reality is actually we are preventing natural death. That if we did not have all these machines and medications, that patient would have died. So we're not actually giving up. I always tell people we never withdraw care. That's one of those little semantics that like always irks me a little bit when someone says, oh, they've decided to withdraw care. It's usually a medical staff who will say that. And I'll be like, we don't do that here. We don't withdraw care. We withdraw life support. We take away machines that are artificially keeping you alive, but we never stop caring. It is the exact opposite. We watch your loved one to their last breath and are the only thing we can guarantee in those situations, if we're going down a comfort care or hospice approach, as we call it, is that your loved one doesn't suffer, they don't feel pain, they're not in agony, and we honor whatever we can for them. So I think for families, the best situation is that they're able to comprehend what I'm saying and they're able to give me the information to be clear on what I need to do moving forward. The most challenging situation is when everyone in the room has a different opinion and they start arguing with each other. And I realize quickly that there's no captain to this ship. And so I'm a bit lost now and I'm going to do everything because that's my job. But I really wish we could have sat down and processed together and maybe come to a decision that would have been more in line with what your patient really wanted. And I think my advice to family members, as difficult as this is really try as much as possible. It's human. We're all a bit selfish. It's in our nature. But really try as much as possible to think about not what you want for your mother, but what your mother would want. So I will tell people, if your mom was sitting in this room, what would she say right now? I'm not saying, what do you want? I know you love your mom and you'd love to have her around for 10 more years. I would too. But in this situation, what would she tell us? And so that is the best thing. When people tell me, I want to keep going, I really do, Dr. Abraham. I want to keep her on the vent for another 10 years if we need to, because I'm not ready to let go. But I know she wouldn't want me to. And because of that, I think we need to stop doing that. I have like the utmost respect for that, where I just say, wow, that continues to wow me when I'm like, that is to me what love is when we can put ourselves out of the picture and actually focus on the person themselves and their suffering and their values. But it's a very difficult thing to do. So I have no judgment for people who don't do that. It's just that that is the ideal scenario in my mind.
And, because there's so many emotions, you're in that
Hmm.
room and you're hearing news that you never expected to hear
Right. Right.
because it's like, well, no, this is my mom. This is my dad. This can't be happening. And being able to switch the narrative of this can't be happening to, okay, what would my mom want? Let me take myself out of this and focus on her. And sometimes I've asked patients to go back to one of your favorite memories with your loved one. And that can help you have that frame of mind of what that person's interest was. What did they love to do? And that all of a sudden sparks an ability to take themselves out of it. But again, it is a challenging situation because when you're in that, it's so hard. We've talked about all spectrums where you are possibly having surgery and then you come out and you're in the ICU, or it was unexpected. So to help people have a head start for just in case if this happens to themselves or loved ones,
Right.
can you tell them what could they do to prepare themselves,
Yes.
for a possibility of a stay? If someone's listening right now, they're going to have surgery and they may even be thinking, well, I'm not even supposed to be in the ICU. You and I know that can happen. Or they've already been told by their doctor, you may have to be in the ICU for a couple of days. What is something that they could do?
This is where we all rely on each other. And I always say, I have so much respect for family medicine physicians like yourself, Dr. Bayo, and so many primary care and family medicine physicians, because ultimately, all that preventative medicine that we do is what's going to increase the odds of someone surviving the ICU. I always tell people it's the condition that you arrive in the ICU, your strength and your frailty and your health and the state of your chronic medical problems will very much predict the likelihood of survival. So if you saw Dr. Bio yesterday, or you saw her 3 months ago, and she said, hey, we really need to do insulin, and you chuck the insulin out the window and you stop checking your shirt. And I'm not judging, I'm just saying the best thing you can do is to really follow your primary care in terms of checking up regularly, getting your blood work, getting your vaccines, taking your medications as instructed. And none of us are perfect, but leading up to your surgery, doing those things significantly increase your chances. I can tell you that smoking, for example, and again, this is a difficult habit to get rid of, but if you have smoked within the few weeks before your surgery, your chances of having a bad outcome when they put you on that ventilator are significantly higher. And so little things like that can really, really make a difference. And then also just asking your surgeon and saying, hey, how risky is this? Are you opening up the biggest blood vessel in my heart? Or are you, taking out my appendix? Those are very different risks. I think just awareness and also talking to your loved ones and saying, hey, if something were to go wrong, you should know that this is what I would want done and not want done. Because yeah, I mean, no one ever expects these things. And sometimes it's an unfortunate thing that can happen. Not to scare people off from doing what they need to do, but I think that would be the best way to prepare.
Well, and the more you know, the more you
Hmm.
can arm yourself with being
Right,
able to make a better decision. And I
right.
have so much respect for you because you have these challenging cases that come in and you are pulling from all angles, just trying your best to, give the best for your patient. The other thing that I love about all of the ICU doctors that I work with, the ability to help people understand hospice and palliative care. Yes, they're specialists, and I'm not throwing any sort of shade to them, but you are that anchor. Can you help people understand? I've talked about hospice and palliative care, but I would love for you to highlight, the differences and the benefit that hospice and palliative care can bring.
I love that question, Dr. Baya. One of the things that I think a lot about and will keep me up at night is not just about our patients surviving, but about them surviving with a good outcome. So I always tell people when I'm in the ICU, like our goal is not just survival. Like, yeah, survival is the low bar, but the high bar is survival and going back and being functionally active and having the life that was important to them. And unfortunately, there are situations where that's just not possible. And I think for me, it's important, like you mentioned, Dr. Bio, and I know you've had some really great guests on here before, to separate those two entities, the palliative care and hospice, because you can't have one without the other. Hospice essentially means that we're moving towards end of life care, and we don't think you're going to survive more than 6 months. And we may be continuing some curative therapies. We may, it depends on each patient. But for the most part, we are sort of switching our philosophy from living longer to living with more quality. So hospice usually means we're moving towards the end of life and we are taking care of ourselves at the end of life. Palliative care is something we can start when we've got 30 years ahead of us to go. Palliative care, all that really means is that you would like to see someone who is going to make sure that they can help you manage the chaos around you with all the things to come with your medical problems. So if you have really bad lung condition, COPD, and you now have to see your pulmonologist and you have to get inhalers, but you also struggle with shortness of breath. And, you're married, but you have two kids and you want to write your advance directive, but you're not sure how to go about it. Palliative care is your best friend. I mean, these are literally these exceptional, kind, loving, compassionate human beings that are just there to guide you as to how you can live your best life, how you can suffer less, how you can feel better. I think sometimes what scares people is they'll be like, I don't want to see a palliative care doctor. I'm not ready to die. And it's like, no, 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 that's not, they're not leading you to the gates of heaven. That's not what they do. Like that's one small niche aspect of their job that they will only do with your consent. And it's not like a gateway thing where we're trying to get you to palliative care to push you into I think people sometimes get scared that we're giving up on them. All palliative care is an ally and a physician who is trained to help you manage your symptoms, which a lot of times is the most debilitating part of your illness. The end of your life is a very hopefully small fragment of your life. It's the years that you have ahead of you where you want to be able to do the things that matter to you. And a palliative care doctor is the best doctor to navigate you through that.
That is the doctor that will help you get
Right,
exactly what you said, the years ahead. And
right,
it can be for a short term. It can be
right,
for a new diagnosis. You get this
correct.
beautiful team
Yes.
around you that can help you navigate all the things that have been happening. Well, before we wrap up, can you give us 3 concrete things that listeners can do today, whether it's being better prepared, knowing what to ask, or supporting someone currently in the ICU?
Sure. Well, I would be remiss to share like my own personal viewpoint, which is that I am very pro-vaccination. And so I know that's become a controversial thing, unfortunately, but I will tell you that from my standpoint, based on my training, my learning, my everything, I think one of the most important things you can do to reduce your chance of ending up in an ICU, especially if you are above the age of 65 years old, or you're between 19 and 64 and you have chronic medical problems, but obviously follow your vaccine schedule and with your primary care doctor, is getting your vaccines. I mean, we are seeing now, especially things like influenza, which the outcomes that are happening right around this time this year, you really might save your grandpa's life if you convince them to get their flu shot this year. So that would be the most important thing. We've learned over years and years that prevention, it's like they say, an ounce of prevention is worth a pound of cure. So what we could have done 6 months ago is way better than what we're doing now to try to make up for what's happened. We can't really turn the clock back. So get vaccinated. If you don't want to get vaccinated, I understand. I don't judge you at all. Just talk to your doctor about it. Be open about what you're scared about. Make sure that you're getting information from credible sources and people that actually care about you. So that's number one. Number two would be try as much as possible to prepare for the impossible, so just be mindful, talk to your loved ones, tell them what's important to you, what you would want done, what you would not want done. And then number three would just be, I hope that people will walk away from this episode knowing that we are really your allies. Unfortunately, and I can't help myself from saying this, we're living in a time where there is a lot of demonizing of the medical profession. And there is a lot of this conversation about, oh, big pharma and things like that. And I can't tell people enough, like, we don't get paid by, we're not getting paid right now by some pharmacy company to talk about vaccines. We're doing these things and we do these things because we really do care about our patients. And I think somewhere along the way, a wedge was put between doctors and patients, and whoever put that wedge there is benefiting from it. But now the doctors and the patients are suffering. And I want people to know, and I'm going on a bit of a soapbox, I apologize, Dr. Bayo, but I want people to know that we have this term in the medical healthcare field called moral injury. And what that means is that a lot of us physicians right now, a lot of us, I'm talking millions of people right now who are healthcare workers, are feeling very hurt and sad because they feel like they have somehow been put as the enemy of the patient and sort of the scapegoat for the failures that they did not play any part in. And so I think it's really important for patients to know that we are your biggest ally. There is no one else who cares more other than your healthcare workers. We are there for you. We are putting in there the work for you. And anyone who's trying to convince you otherwise does not have your best interest in mind. So that's my sound bite. I appreciate you, Dr. Bayo.
It was perfect. It was spot on. This conversation has been incredibly valuable. I know you've helped our listeners understand what's really happening behind those ICU doors, and more importantly, given them the knowledge they need to advocate effectively for themselves or their loved ones. For those who want to learn more, you can find our guests all over social media as ICUBOY. We also have the links in our show notes. Any final notes before we go?
No, I just want to thank you so much, Dr. Bio. You're such a incredible role model, not just about being an exceptional physician and just an exceptional human being. And the fact that you're doing this show and your audience is primarily our patients and all, the general population, and really trying to bridge this gap and help people feel empowered and understand things that are hard to understand. I feel so honored really to even be invited here. So thank you so, so much.
I'm so honored to have you as a guest, and I'm honored to have your friendship and
Of
everything.
course.
Did something in this episode change how you think about the ICU? Share it with someone who might need to hear this. Whether you have a loved one in critical care right now or just want to be better prepared for the unexpected. Because here's the truth. The ICU can be an overwhelming place, but understanding what's happening can transform fear into empowerment and help you be the advocate your loved one needs. Knowledge is power. You've got this. Yay!
Yay!
Oh, this is wonderful. Thanks for listening to Beyond Clinical Walls. If you learned something new today, please leave us a review on Apple Podcasts or Spotify. It really helps us reach more people who could benefit from these insights too. Hit subscribe so you never miss an episode. We've got amazing content coming, including great episodes with the health creators you love.
You've heard the truth, now take the lead. Stand for yourself, know what you need. One step closer, you've made your mark. Keep showing up and light the spark.